Now, our second presenter is Claudia Bilodeau. So her talk will be Beyond the Cough, an update of interstitial lung disease. Claudia Bilodeau is in the medical science liaison at Boehringer um, Ingelheim, specialized in interstitial lung disease. She holds a master's degree in cystic fibrosis research from Université de Montréal. And following that, she completed her master's and then she completed her PhD in lung development, stem cell biology, and regeneration from the University of Toronto. With her research driven background in pulmonary biology, she bridged the science and medicine with advanced understanding and innovation of respiratory health, guided by her compassionate commitment to improve the lives of patients affected with complex lung disease.
Bon matin tout le monde! Comme on vient juste de le dire, je suis MSL chez Boehringer Ingelheim en maladie pulmonaire interstitielle. Puis je vais continuer en anglais, mais à la fin, si vous avez des questions en français, n'hésitez pas. Okay, so hi everyone. As I was saying, I'm the MSL, so medical liaison for Boehringer Ingelheim in pulmonary lung fibrosis. So I just want to thank the organizer for having me today. And I was asked to present an update in ILD. So I'm going to talk to you about interstitial lung disease. Okay. So the first thing is really for the patient to recognize the symptoms. So from a patient point of view, symptoms are highly unspecific. So the patient who will experience symptoms might start with shortness of breath on their daily activity, and that they might even confuse that with getting out of shape. Or simply just aging. So there might be unexplained fatigue, cough that might be or might not have started with an infection and it's not getting away. So the first real thing will be for the patient to recognize that something is not quite right. So that is when you will have a patient showing up at a primary care provider door. But there are also patients where there will be no symptoms, and those ones will be the hard one to catch. So the patient arrived at the clinic with these really uncharacteristic symptoms that could be attributed to so many diseases. So as you see here, the cause of dyspnea are multiple and sometimes not even directly connected to a lung disease. It could be COPD, asthma, cancer, ILD, pneumonia, but it could also be cardiac cause, like congestive heart failure, arrhythmia, ischemia, or systemic disease like anemia, anxiety, or liver disease. So really the care provider has the hardest job. They have to think of all these diseases and do the history, the physical exam, and that should eventually lead to some investigation. So the primary care provider will ask questions on the history of dyspnea. So the pattern of them, what triggers them, the duration, the associated symptoms such as cough, phlegm, wheeze, exertional, thoracic chest pain, edema, then smoke exposure, cardiac risk factor in history, and so on. So then you will identify the diagnosis physical red flag. Sorry. Crackle, wheeze, reduced air entry, arrhythmia, clubbing, focal chest finding, like all of those things. And finally, it will start with an initial diagnosis and it will start testing. So maybe X-ray plus or minus radiographic evaluation. Then spirometry, ECG, they could have some blood work to be done. And then the further they explore the symptoms of the patient, they will direct the patient to a subsequent investigation or referral, and then different algorithm may be started. So it's not rare in the diagnosis of ILD that it's delayed or that it's really just misdiagnosed for COPD or something else, because there's so many other things that could give them dyspnea. And then also, as you all know, a patient is rarely one single clean disease, and they might have other comorbidity that complicated the diagnosis and are clouding the current new working diagnosis. So, for example, emphysema is found in up to 50% of patients with IPF. There's also a good proportion of patients with IPF, sarcoidosis, or scleroderma, who will also have pulmonary hypertension. Obstructive sleep apnea is also highly present in lung fibrosis. And patients with IPF also have higher chance of getting lung cancer. So now we're really getting into the subject. What is really lung fibrosis? So there are different exposure, different cause of it. So you can be exposed to environmental hazard, inorganic, like coal, dust, asbestosis, tobacco, smoke, and what we saw in the presentation before, or organic, like bird feather, mold. So it could also be part of pathology of an autoimmune disease like rheumatoid arthritis, scleroderma, lupus, dermatomyositis. There's also certain medication that have been linked to ILD, like sulfonamide, bleomycin, and radiation when you have therapy delivered to the chest. Genetic factor and predisposition also can give you ILD, and sometimes you just don't have any idea. Like it's unknown. So you can have idiopathic pulmonary fibrosis and SIP, unclassifiable ILD. Pulmonary fibrosis is the term we use to describe the fibrotic change in the lung. And this change are almost always irreversible. They are structural change to the lung, and we cannot go back to this, to the normal lung after that. So let's dive more into the pathophysiology of it. So interstitial lung disease, ILD, is really an umbrella term for a large group of disorder that affect the interstitium part of the lung. So the interstitium is really the lace-like network of tissue wrap both lungs. And it is the space between the alveoli, like the air sac, and the blood vessel. So basically, that's where the gas exchange happens. So normally the interstitium is so thin that he cannot show up on an X-ray or a CT scan. So in an healthy lung, you will have the alveolar epithelial cells and the capillary, and they will be both part of the alveolar capillary barrier, and the interstitium is really the space in between them. Now in ILD, the lung tissue will become really stiff and dense, and then that will impact the gas exchange. So pulmonary fibrosis is not a synonym of ILD. It's really the cellular process, and then ILD is the disease. And the presence of pulmonary fibrosis of PF doesn't necessarily mean that you will have progression. So pulmonary fibrosis is really more like a scar. Okay, so ILD disease are large and heterogeneous group of inflammatory and fibrotic condition. And as you can see, there is IPF, that's the most common one, but ILD can be found in many other conditions like RA and sarcoidosis. And the ILD prevalence is really hard to evaluate. So we have more data about IPF, and globally, North America is more affected, with Canada and US leading really the way there. So what is IPF? So idiopathic pulmonary fibrosis. It's a fatal disorder of unknown etiology with a very high mortality rate, worse than several cancer. The natural history of IPF differs greatly between patients, but it involves a decline in lung function. So it worsens quality of life, and eventually it leads to death. From the time to diagnosis, the median estimated survival is 2 to 5 years. That being said, now we have new standard of care treatment established since around 10 years, and we have more precise instruments that allow us to diagnose earlier. So we hear that the survival might have increased, but we have no real number to support that. So other than the small country-dependent cohort study, so we have a Danish one with 260 patients, and from that, about 67 were receiving nintedanib or pirfenidone, which is the treatment we have for those patients. And the median survival for those patients were, after the first visit, was 4 years. So IPF remained a really poor prognosis disease. So it's a really progressive fibrosis interstitial pneumonia with unknown cause. So shortness of breath, dyspnea, especially when you're doing mild activity, like climbing a flight of stairs. That's the most prominent symptom, and it affects nearly all patients. The patient will likely feel breathless, even at rest. A dry, hacking cough that doesn't get better over time, the patient may have repeated bouts of coughing that they cannot control. That affects about 70% of the patient. Then they will have you have inspiratory crackle that affect more than 80% of the patient. And then you will have weight loss and malaise, a general feeling of being unwell, and fatigue, tiredness that may be dominant. And then about 20 to 50% of the patient will have finger clubbing. So, well, it's recognized that symptoms precede the diagnosis by a median of like 1 to 2 years. And even radiographic evidence of disease may even precede the symptoms. So there's a subclinical period that it's not really well characterized. So it's a really rare disease affecting more men. In an analysis of 18 observational study from 12 countries, the estimated prevalence of IPF ranged from like 3.3 to 45.1 people over 100,000 people. So for every 1 year increase in age, the prevalence of IPF increased by 6.2%. The estimated prevalence in Canada is 41.8 person per 100,000 inhabitants, with New Brunswick making no exception, between 40 to 50 people per 100,000 inhabitants, depending if you are male or female. So all patients with IPF are at risk of acute exacerbation, defined as an acute, clearly significant respiratory deterioration, characterized by evidence of new widespread alveolar abnormality. So the median survival of patients with IPF will experience an acute exacerbation is approximately 3 to 4 months. So in a retrospective review of 461 IPF patients, they found that the immediate outcome of acute exacerbation was really poor. So the median survival was 2.2 months from the onset, and half of the patient died during the hospitalization. So as you can understand, this is an important risk factor for mortality in IPF patients. So also the lower your FVC is, the more chance you have to do an exacerbation. And an exacerbation is basically just like new worsening of dyspnea, cough, fever, flu-like symptoms, severe hypoxemia, and then respiratory failure that may require mechanical ventilation. To have a diagnosis of IPF, you need to exclude any other cause of ILD. And then the presence of usual interstitial pneumonia pattern, so a UIP pattern on an HRCD. And then, or you can have a possible UIP pattern or a presence of definite or possible UIP pattern, and then you need to confirm that with surgical lung biopsy. There's many patients that are not able to undergo surgical lung biopsy because of the advanced age of comorbidity, and that impacts the diagnosis. So IPF leads to declining lung function. And as you can see here from the US IPF Pro Registry, the average this patient was losing in lung function was 2.8% absolute predicted per year, or DLCO, they were also losing 2.9% per year. And as you can see here, IPF is really associated with substantial healthcare resources use and cost. Okay, finally, for IPF, this is highly unpredictable. While some patients are progressing in a flash, while others are just being stable for a couple of years, and then it will progress. So far, we don't have any clear tools to distinguish which patient is going to progress. So let's talk about the other ILD. So let's call PPF. So PPF is defined as progressive pulmonary fibrosis. So not every ILD is PPF, no. So the signs and symptoms of fibrosing ILD are really looking the same as IPF. Dyspnea, crackling, weight loss, tiredness, and early symptoms like cough and breathlessness are non-specific and may precede the diagnosis by up to 2 years. So as I was saying, not every ILD will be PPF. But in part of patient who has ILD, the scar tissue will continue to build up. Then their respiratory symptom will get worse. Then the cough and dyspnea will get worse. And then your physiological measurement, like FVC, will be impacted. And eventually that will lead to decline in quality of life and early death. When you look at the proportion of patients with ILD in Canada and the US, you can see that IPF only accounts for 20 to 25% of ILD cases. There's still a large proportion of patients that is 20 to 20, that have IPF, and we know that IPF is the worst prognosis. So this was why the group of IPF patients was first studied, and it was the first one to receive a treatment. But now we're extending to all those PPF or PF-ILD patients. So there are risk factors associated with progression, like fibrotic pattern, if you have a UIP pattern, the rate of lung decline, the acute exacerbation, the genetic predisposition. And again, those patients, like IPF, they are not just one disease. They have comorbidity that they should be treated for. So they have emphysema, obstructive sleep apnea, lung cancer, and they also have pulmonary hypertension. In 2022, there was a joint publication by ATS and ERS to define what was progression. So this is when the term PPF was defined. Basically, you have to fill at least two of these criteria to be considered having PPF. So worsening of respiratory symptom is one, and either after that you can have absolute decline of FVC of 5% predicted or more, or absolute decline of 10% or more predicted of DLCO in a year, or radiological evidence of progression on the scan. So you need two of those criteria to be considered progressor. And they also published a list of ILD that could progress, where you see in the blue grayish line that represent the percentage of these patients with ILD that are at risk of progression. So you can take RA-ILD, for example. So from all the RA patients in the world, like around 10% are considered to be having ILD. And from those 10% who have ILD, about 40% were at risk of progression based on this study. So patients with PPF have a poor prognosis, irrespective of the criteria they use to identify their PPF. So as you can see here in the respiratory survival curve, FVC is normally used as a surrogate for that, though. And so finally, what the guideline recommend to do for monitoring is to look out for worsening of symptom, and that's just objectively assessed. And then complication, comorbidity, then worsening of oxygenation, and they ask you to look for a decline in fibrosis or PFT. So that could be look for a PFT or HRC. Okay, so now we look at treatments and hopes. So the physical, social, and emotional impact of ILD include managing home life. As you will have decrease in physical function, it will impact your daily life activity. So that's what the patient mentioned the most. This includes struggling to perform basic activity, such as walking up the stair, showering, housework, and getting dressed. There's also impact on work and career that could lead to early retirement, giving up the thing they love, and they feel a lot of isolation, and it impacts their relationship. So it's really important that we find something to help these patients that are hopeless when they're facing their progressive disease. So far, there are non-pharmacological treatment, and that will include smoking cessation, oxygen advanced care, rehab, and eventually it could be transplant and palliative care. On the pharmacological side, depending on the underlying disease, the specialist that you are seeing, patient might be on different immunosuppressant modulator and antifibrotic to control the systemic disease and try to limit the lung progression. But as you see here, when it comes to lung fibrosis, there's only two antifibrotic options currently on the market, both with their share of side effects and non-completely stabilizing the disease or curing it. They offer a reduction in the decline of lung function, which could possibly prolong their life in the long game. As you may have heard, they are obviously no drug is, but the management of the side effect is challenging for the patient, and the decline in lung function is still happening. So there's a gap and a need for the patient to improve quality of life and to find better options. So since the approval of those two antifibrotic, like about 10 years has passed, with a series of phase 2 and 3 who failed. So from the Panther trials a couple of years ago to the Isabella trial and recently the Beacon trials. So many molecules that were promising did not fulfill their full promise.
You have 2 minutes, Claudia.
Yeah, it's my last slide.
Good.
But there's many IPF and PPF quite ongoing. And so it's really encouraging decade for this patient as we are looking at much more to come than what have been done in the past. And to this, we saw the first positive trial, the phase 3 trial this year with the Fibronia trial, and the second one with the Teton trial that was also announced as positive last month. So hopefully we're only the beginning, and the other coming like autotaxin inhibitor, and the alpafenidone and nintedanib and deupirfenidone will follow the trend and offer more possibility for the patient. So early intervention is really what could help preserve lung function for this patient, and hopefully much more and better treatment coming, preserving the better quality of life for this patient. So in conclusion, pulmonary fibrosis, the challenge are really first to recognize the symptoms, then for the patient to face the diagnosis and the prognosis coming with it, and to carry a battle that for the moment nobody wins. But there's hope. With clinical trial ongoing, there's also incredibly talented clinicians dedicated to these patients across Canada, including New Brunswick. And there's many resources for these patients and clinicians, including the CPFF website. So with that, that's it. Really merci, and thank you for everyone for listening. And hopefully nobody's going to sleep now.
Merci beaucoup. Thank you. So we don't have any chat question, but I do have a question. My question is, one of your first slides, you were saying that sleep apnea is associated to the pulmonary fibrosis. Can you explain me a little bit more? What's the relation between those two?
So, good question. So basically, just because the oxygen is having a really hard time passing through the barrier that I showed before, just how that happened. So patients are really not able to oxygen themselves, so they will feel that dyspnea first when they do exercise, and then, but exercise doesn't need to be a lot. So just the oxygenation process is really hard to do. So they will see they will clearly have problem to just put oxygen in their blood.
So there's a delay in their oxygen because of the thickness of the lung, and that can create some sleep apnea?
Exactly.
Okay. Is it so? Okay, I see that. Well, that was a very good presentation, and it follows so well with the next presentation we will have, because you said in your one of your last slide about pulmonary rehab and quality of life and how to help with that. So that's our next slide, our next group of speakers.